I think there's probably four main problems that we have with our posterior composites as dentists. Firstly, that of isolation. Secondly, that of dentin bonding failures, whether that's very early or later in the life of the composite. We can have problems creating contact points, contact areas. The matrix systems, the matrix bands that we're used to using for amalgam aren't necessarily appropriate for composite. And we also get material failures over time. This can be due to bad layering techniques. It can also be due to bad light curing techniques, or actually having an inappropriate light cure unit. So the idea really over the next 55 minutes or so is to talk about these main problems that I see. So first of all, I'm going to talk about isolation and bonding. I'd like to introduce you, if you're not aware of it already, of a technique called deep margin elevation, which was first really developed for onlay preparations to deal with these subgingival preps. And then I'll talk about contact areas, talk about circumferential matrix systems, and the active systems that we can also use. I'll talk about how to avoid having to use multiple layers and talk about the bulk fill technique. I'll then also talk about the composite for root fill teeth. And then finally, I'll talk a little bit about light curing, and I'll talk a little bit about how to create good anatomy with your posterior composites. So why do we use composite at all? We're all using this material. Patients are requesting it. We have a patient comes in with these unsightly amalgams in the premolars that we replace with composite. The patient's very happy. They don't see the amalgam. There's no, the moment that you replace that amalgam with composite, the whole tooth brightens up, and the patient's very happy. So certainly our patients are requesting these for aesthetics. Dentists are liking this material for the minimal preparation involved compared to amalgam. It's questionable, I think, about reinforcement of tooth tissue. I think some papers would say it absolutely reinforces tooth tissue, others that it doesn't particularly reinforce tooth tissue. But I think it reinforces certainly more than amalgam. Also, patients are concerned about mercury and amalgam toxicity. So patients don't really want these amalgams in their mouth if they might not be safe. And then finally, dentistry is also going to have to deal with the Minamata Convention, which, if you're not aware of what the Minamata Convention is, I suggest that you just Google that or type that into Wikipedia. But this is something that the whole world has signed up to, which is essentially going to lead to a phasing out of amalgam, probably over the next 5-year, 10-year period. When we look at amalgam versus composite and what does the evidence tell us, this is from the Journal of Evidence-Based Dental Practice in 2008, and it was looking at survival and failure of amalgam versus posterior composites. Now actually amalgam came out better than composite, and the conclusion from this study was that they were doing better, and the difference was particularly accentuated in large restorations and in those with more than 3 surfaces involved. I think, though, that as the materials are better, the techniques are a lot better. I think if this was done now, it would be far, far closer. And I think certainly in my own hands, I'm more than confident enough that my composite restorations are going to last as well as my amalgam restorations. And it's not that I've deliberately phased out amalgam for any other reason than I think it is the best type of restoration for my patients. Now, why do composites fail? This is a patient that attended my practice. These upper premolars with failing composites. We can see some leakage, we can see some breakdown of the material. The patient's getting food stuck here. And it's not unusual to see weak or no contact points. The patients will complain of food packing, irritation in the gum. Even if there is a contact point, so we put floss in between and it snaps through, the contact area can be the incorrect shape. So you can still get food packing and still get periodontal problems. We see overhangs, we see voids at the base of the box. And then with these composites breaking down over a period of only a few years in this case, it's often because of contamination with blood or with saliva. This obviously leads us to longevity issues. Wear resistance, I think, is less of an issue now with certainly an issue with composite materials 20 plus years ago, but less of an issue now. And some dentists do report still post-op sensitivity with composites, which I think it can be due to occlusal problems, but I think in most dentists' hands, these post-op sensitivity problems are largely due to failures of dentine bonding. And composites, not so much for me, but I think for quite a few dentists that I speak to, can be a hassle. You're having to deal with blood, crevicular fluid, saliva, the tongue wanting to get in the way. They can be a bit of a pain to do. And we can get problems with patients coming back with post-op sensitivity or with food trapping, which is not good for your practice. So I think the number one thing is really to be considering rubber dam isolation. Now, this was a study from the British Dental Journal a few years back that looked at the attitudes of general dental practitioners in the United Kingdom to the use of composite materials in posterior teeth. And when they looked at rubber dam usage, dentists were reporting sometimes 48% were using rubber dam, always 12%, but never using rubber dam was actually quite a high percentage, 40%. Now, I think also studies like this tend to report more positively on rubber dam usage because the type of dentists that fill in these surveys tend to be the keener dentists that are using rubber dam more often. And talking around in the UK about rubber dam use, having spoken to hundreds and hundreds of dentists about posterior composites and rubber dam usage, I would suggest that those numbers, the never is certainly much higher and the always is certainly much lower than that. And it's really a surprise to me because the advantages of rubber dam are great. We have a nice dry field, we have great visibility, the patient doesn't have to get up and rinse their mouth all the time. We have therefore increased efficiency. It's less stress because we're not having to battle with tongues and with cheeks. And we also get the advantage of cross-infection control, that we're not creating this aerosol spray with our high-speed handpieces of blood and saliva. So I think there's a lot of great advantages for rubber dam, provided we can place it quickly. Now, one of the webinars that I've done in the past for Dentsply focused purely, or largely I should say, on rubber dam and technique. So if you're not happy with your rubber dam technique, perhaps go and have a look at the Dentsply Academy webinar that I did on rubber dam. Now, the disadvantages, these tend to be reported by dentists that don't use rubber dam routinely. Firstly, that it takes too long. A typical isolation, as I'm showing you here, just of these 3 teeth, and I'm working on that 6, would probably take me about 1.5 minutes to isolate. So I don't think it takes too long. But if you're not used to using rubber dam, and if you think back to what you were like at dental school, it might take you 10 minutes or 15 minutes plus. So it is a case of practicing to get your technique down to about 1.5 minutes for this type of isolation. It's too difficult. Again, it's just practice. It costs money. Certainly a sheet of rubber does cost money. The rubber dam clamps are obviously autoclavable. The frames are autoclavable. I think the time savings, the efficiency savings, far outweigh the cost of the rubber. And then the other thing I hear is that patients don't like it. Again, I think I've come across probably one patient in the last 20 years that couldn't tolerate rubber dam placement. He was a very claustrophobic patient, but that's in 20 years, one patient. And he'd reported that an endodontist had also tried to put a rubber dam on him, and he had exactly the same issue. So I've had one failure in 20 years. Patients, I think, if they're told of all the advantages of rubber dam, they actually do like it, and I think actually do prefer it, that they're not getting mouthfuls of metal fillings being drilled out and having to have constant suction and having to get up all the time to rinse out. A lot of my patients are very, very happy with rubber dam. There are times though when it can be difficult. In this case, actually that I just did a couple of weeks ago, you can see this, the distal box in this 6 is very near the gingiva. So what I've actually done here is to use a split dam technique, and I'll talk about in a second. We can use something like a deep marginal elevation technique just to raise that margin, and then I can put on a regular rubber dam and finish off with an active matrix, which I'll show you in a moment. So there are times when you have to adapt your rubber dam technique, such as in this case. Now, the deep margin elevation technique, this was originally described by Didier Dici and Sprefico back in 1998. So it's not a new technique, but Magnier and Sprefico wrote this up in the European Aesthetic Dentistry in 2012. And really what they were looking at was a way of being able to place onlays on teeth, perhaps that had been heavily restored with amalgam. This is one of my cases, such as this. And once we remove this amalgam, like this, then we see we've got a problem. We have these slightly subgingival margins. And even once we clean up all the prep, we wouldn't want to start then prepping that for an onlay or a crown. Because when we come to cementation, we're not going to be able to adhesively cement very effectively in this kind of situation. So what we can do is this deep margin elevation technique, where we place a regular conventional matrix band. It could be a Siegland, a Toffelmeier, an Omni matrix, as in this case. Garrison make a very nice deep, very, very thin band, which is designed particularly for this technique, which is just about 3 millimeters or so, and it very, very nice at getting subgingival. And we use our dentine bonding agent, so we get this nice glossy appearance, and then we can fill that with composite. In this case, I think I've used SDR just to fill up the base and basically raise our margins, and then we finish off the preparation so that then when we come to bond our ceramic onlay a week or two later, or if you're a CAD/CAM user, it could be that would be the point that you would then scan the tooth, and then we can cement our ceramic restoration, in this case an EMAX restoration, where our margins are all supragingival. So the advantage we have here is that we've placed our base, our adhesive base, in under ideal conditions. I go back. So this is fairly ideal, not perfect conditions, but ideal conditions compared to what we had here. So we've placed our base, we've placed our composite, so we've raised the margins like so, and then we can bond on our onlay either later that day if it's CAD/CAM, or a week or two later if it's laboratory made. And once the rubber dam is on in that case, we now have perfect conditions for bonding to. We can also use this same technique, and I'm using this same technique when I'm doing posterior composites. So So we've removed this amalgam. We've decided we're going to do a posterior composite. But when I take out the amalgam, you'll see that we have slightly subgingival margins. So again, what we can do is place a conventional matrix, bound again in this case an omni matrix, place our dentine bonding agent, and essentially then just raise our margin. Then we could go on then from that position to place our rubber dam, and as I'll talk about shortly, place then an active matrix to then create our nice contact area. Now, just a little bit about dentine bonding, because we only have an hour together, and you know, I could quite easily go on for an hour just on this one slide. But the key with dentine bonding, I think, is to know your material. And it sounds obvious, but to actually read your instructions. And we have here the fourth generation, as it's known, fifth generation, sixth generation, seventh generation, prime and bond dentine, which is one of the fifth generation. Now, all dentine bonding agents are essentially the same, as in we have an etch, so we have an acid, we have a primer, and we have a bond. And the fourth generation were three separate stages. So we would have a separate syringe of phosphoric acid, 37%, would do a total etch technique, would wash, would suction dry or 3-in-1 dry, would prime, would then leave that primer for 20 seconds, then would put on our bonding agent, and then would light cure. Now that was obviously seen as a bit too complicated for dentists, so fifth generation materials came along, where we have, again, total etch, and then we have one bottle of the primer and the bond all together. And if we're using a fifth generation material such as prime and bond dentine, then we always need to be careful that we sort of mix this, we shake the bottle well before every use, because otherwise the prime and the bond can start to separate. Then the sixth generation came along, again two stages, one bottle which would contain our acid, so our etchant, and our primer, and then a separate bottle of bond. And then the latest fashion is to have everything in one stage, so the seventh generation. So we have the one bottle system, so we have etch, prime and bond all in one bottle. Now, my preferences, I would say, to use fourth and fifth generation systems. I think sixth generations are certainly proving themselves very well also. Seventh generations, I think there's probably not enough good data for me to be using seventh generation as yet. But it's kind of watch this space, I think, with the seventh generations. That's certainly the sort of the holy grail, I think, for dentine bonding, if we can achieve great long-term bond strengths. But the key with any of these systems is to read the instructions. Sounds very obvious, but it's amazing how many dentists don't read the instructions. They don't know whether they should be, how long they should be applying the etch for. They don't know how long they should be washing for. They don't know how long they should be priming for, whether they should be agitating the prime and the bond, or whether it should just be left there. And it will depend from manufacturer, and it will change and vary from manufacturer to manufacturer. So it is important to read the instructions very, very clearly when you start to use a new dentine bonding system. And also the other key with bonding is to avoid contamination, which is why we first started off talking about rubber dam, because the moment that you've put some etch onto a tooth and clean that tooth, the moment that you've put your etch and prime onto the tooth, or your one-stage system onto that tooth, if that's contaminated with saliva or blood, that can absolutely ruin your bonding. Now, next thing, contact areas. How do we create them? And certainly when I was using your standard amalgam type matrices, such as Sieglins and Toffelmeyers. This is often how I created them, by really crossing my fingers and hoping for the best. And when I removed the band, expecting the floss to be nice and tight and not to have any open contact. And this was when I was wedging the teeth apart. I was burnishing the matrix band as well as possible. And this is what I used to use, just a circumferential type matrix, which can be described as a passive matrix. And a circumferential type matrix is often just a straight matrix that you would then have to burnish. So if we look in diagram 1, we're going to restore the distal aspect of this tooth. We have a straight matrix band. We then pack our composite, and then we remove the matrix band, and what we're left with often is a fairly straight contact area. So teeth aren't naturally straight like this. They have curves. They have the contact area in this region here. Hopefully you can see that with the little pink cursor that I'm moving around. So it wouldn't be straight, it would be a nice curve like this. We have a contact area up here. And we also often end up with a tiny gap which relates to the thickness of the metal matrix band. And therefore that tiny little gap is going to get food trapped. Even if it is tight here, because of the anatomy here, we can get food trapping in here, causing periodontal problems. So that's with a typical circumferential type matrix. I think if you're using these for your posterior composites, you really are sort of doing what I used to do, which is crossing your fingers and hoping for the best. So really what I use pretty much exclusively for several years now is a sectional type matrix, or an active matrix system. And the active sectional type matrix, first of all, the big advantage is that the matrix itself, as I'll show you in a moment, is curved and it's more anatomically shaped. And then there's an active component which separates the teeth, so that then when the composite is placed, as in diagram 3 here, once the band is removed, the tooth springs back and we have a nice contact area and also a nice anatomical shape. Now, Dentsply, with the original Paladent system, were really the originators of these systems. This photograph on the left here. It certainly worked. I've done cases with it, but a little bit fiddly. They then produced the Paladent Plus system, which is on the right here, which is what I now use in my practice. And it's great for giving great anatomical contour, good emergence profiles, and tight proximal contacts every time. This is what the kit looks like. You have some forceps, you have what are called pin tweezers, and I'll show you these in detail in a moment. You have a couple of rings, clamps, which will help separate the teeth. You have a series of different sized wedges and a series of different sized matrix bands. These are the matrix bands which are pre-curved, pre-contoured. They're anatomically shaped. They come in 4 different sizes, and they have these little perforations on the sides, which I'll show in a moment, of basically for picking these up with some pin tweezers. You have some nice anatomically shaped wedges that come in 3 different sizes also. And you have a couple of different rings, a universal ring and a premolar ring, which will basically just give you a slightly greater separation, slightly greater force used for premolars. Comes with some forceps, which are very similar to rubber dam forceps, and they're used for essentially separating this sort of bi-tine ring. It's made of nickel titanium now, rather than stainless steel, which has a much better memory wants to go back to where it started from. And as you'll see in the diagram shortly, it's this ring that holds both the band in place and also creates your slight separation between the teeth. Also in the kit, you have some pin tweezers, and these are essentially for manipulating and carrying the wedge and the matrix to the tooth, like so. And just to show you this on a model, before I show you some clinical cases, it's very simple. We pop in the matrix band first of all, and the idea is to select the correct size. So this tab here is flush with the top of the marginal ridge of the neighbouring tooth. And if this is flush with the marginal ridge, it means that the contact point, the contact area, will be in the correct place. And then we can pop the wedge in, basically just to close the base of the cavity. And then we place the clamp over the wedge, which will then hold the matrix in place, and also just imparts a little bit of pressure just to separate the teeth, like so. The clamp can either point distally, as in this photograph, or it can point mesially, like so. It doesn't really make any difference. Whatever suits you. Also, if you're doing MODs, and I'll show you a clinical case a bit later, you might have one clamp pointing one way, the other clamp pointing another way, but also it's possible to stack them on top of one another, and it's as simple as that. I think the first time you use a system like this in practice, it's a little bit frustrating, it's a little bit fiddly. I think once you've done about 4 or 5 cases, it becomes second nature, and it becomes just as quick as placing a circumferential matrix band. Just to show you clinically, so we have this failing composite in the distal of the upper 4, and we can use, this is another little neat feature in the kit, as well as the wedges that you can get. They also come with these little stainless steel guards, so you can actually, before you do your preparation, before you remove the composite, you can pop one of these guards between the teeth, and what it does, it just protects the neighbouring tooth, because studies certainly show that even though dentists think that they're very skillful and that they don't touch the neighbouring tooth ever, we actually more often do than not. So this is just a way of protecting, and then what you can do is put your pin tweezers into this the hole here, pull out the guard, and then you're left with your wedge, and then you can pop your matrix in there. So there we are with the composite removed, with the rubber dam in place, and there's our matrix band. As I said earlier, we have this little tab flush with the top of the marginal ridge of the other tooth. We have our clamp in place. We fill in a few layers, and we remove, and we have a nice anatomical shape, and we have a nice tight contact. And if we compare that to where we started, where it's actually very bad shape and bad contact, the patient's getting food stuck in there, patients are much happier with that restoration. Now, the next thing I want to talk about is avoiding multiple layers with our composites. Now, we have a cavity, such as this. We place a composite, we light cure it, and then what happens is that the composite shrinks. And it typically shrinks about 1.2 to 4.5% by volume. And that shrinkage by volume can obviously put a lot of stress on cusps, can create post-operative pain, can create little fractures within the tooth, little microfractures in the tooth. And also with that shrinkage, it can basically rip the composite and the dentine bonding agent away from the floor of the cavity, which is often the cause of post-op sensitivity. So what is it that dentists do to try and counteract the effects of this shrinkage is to build in layers. I think most dentists using conventional composite would be doing that. They would be building perhaps a base layer of flowable composite, which if you do use flowable composite, that really should be about 0.5 millimeter thick, which just helps you adapt the next layers, and each layer should be no more than 2 millimeters. Otherwise, you won't get a sufficient depth of cure, and so that's what a lot of dentists doing. But as I'll come on to when I talk about root-filled teeth, sometimes these cavities are very, very deep. So we might have 6, 8, 9, 10 millimeter deep cavities, perhaps in a root-filled tooth. So that's lots of layers. That's lots of time. So to counteract this, the Dentsply produced a material SDR, which was released about 5 years ago. And this was really one of the first, and I think the first of the bulk fill type materials for posterior teeth. It's in service in about sort of 30 million restorations. There's numerous studies now following up this material in patients, which I'll come to a little bit later. But essentially, you have a compule of material. It has quite a neat little metal nozzle, whereas obviously a normal compule would finish here. So it's basically an injectable material. And the idea is that rather than building in layers, as on the left here, where we'll have perhaps a base of flowable composite, and then we'll build a layer 2 millimeters, 2 millimeters, 2 millimeters, 2 millimeters. So we might have 4, 5, 6, 7 layers building up a large restoration. What we can do is, in the dark blue here, we can fill the bulk of the cavity with SDR, and then we can just cap the SDR material with any kind of nanohybrid, hybrid, microhybrid type composite that is suitable for posterior use. So SDR, although it appears to be a flowable type composite, and it's a flowable composite, it's not used in the same way that a flowable composite would typically be used. The volumetric shrinkage of a flowable composite is 6% or more. For SDR, less than half of that. So this is actually a bulk fill composite. The reason why SDR can be used like this is essentially the Dentsply managed to put something called a polymerization modulator into the backbone of the resin, which basically slows down the cross-linking of the resin material. So the material does still shrink. It's not a no-shrink composite, but as it's shrinking and setting, as it's curing, it develops low stress. So it's suitable for 4 millimeters deep layers. So double what we would normally be doing with a traditional composite. Now, to test this, what I did was I was given this little piece of plastic with an 8 millimeter, a 6 millimeter, a 4 millimeter, and a 2 millimeter little steps within them. And what I did was I filled the 8 millimeter step with SDR, which, as you'll see, is a little bit sort of greyish looking material, and that's because it's quite translucent, which allows you to cure in depth. And I filled the 6 millimeter just with a regular nanohybrid composite, and then I cured them both from the occlusal surface, from the top there, for 20 seconds with an LED light, and then turn it over. And this is my SDR, this is my regular composite, and then I did a scratch test just with a sharp instrument, and you'll see on the right here, the regular composite hadn't set at 6 millimeters, whereas the SDR had set at 8 millimeters. Now that doesn't mean that you can use it 8 millimeters deep. The recommendation is to use it at 4 millimeters, but I think it's a really, really good test to do, just to convince yourself that this stuff actually is curing at that depth. Now, as I just mentioned, one of the perhaps criticisms of SDR that's been leveled at it is that it's a little bit translucent. Now that's really not an issue, because if we have a cavity like this in this model with some a really, really dark spot, we place our SDR and most of that dark spot disappears anyway. But once we place our capping composite on top, nothing is shining through whatsoever. Okay, so it's really, really not an aesthetic issue, and as I'll show you towards the end with a few more cases, it's really not an aesthetic issue at all. The data seems very, very positive. This is Dentsply data, 24-month study, which I think has now been extended to 36 or perhaps even longer than that, where there's no failures associated with the base material. The Birmingham in the UK prep panel, Trevor Burke and others, when they reviewed it, they gave it a very positive review. Reality in the USA, which is a very well-respected independent research laboratory, gave it also a very good 4-star review. And Clinicians Report, CRA, they also looked at it and tested it independently, and they also said, this material seems to do exactly what Dentsply claim. So I think perhaps 5 years ago when I first started using the material, it was a little bit of a leap of faith. I think now, 5 years on, the data's there. I've placed, I think, probably over 1,000 restorations using SDR now. And touch wood, I've not seen any issues because of using SDR. Now, the other indication that's, I think, actually really, really useful is to use SDR in root fill teeth. And the importance of a good coronal restoration as well as a good root filling, I think is known by all dentists really. It's not about just doing a good quality endo. It's about providing a good seal. Now, patients don't particularly want amalgams in their mouths. The problems, though, with placing composite into these root fill teeth, I think, is the depth is one thing, because often these cavities are sort of 8, 9, 10 millimeters deep. Now, and SDR really, I think, is great for that. Now, typically, if we're trying to sort of pack down into a root canal, it's whether we can manipulate the composite material right down on top of the root filling. Can be really, really tricky. Knowing that we've only just placed 2 millimeters and no more can be really tricky. So I think one of the reasons why composite in root fill teeth developed a bit of a bad name was because of this, is that dentists were not layering correctly because it was very difficult to adapt the composite at the depths of the root canal, and building up in not 2 millimeter layers but 3 or even 4 millimeter layers with conventional composite, and therefore the composite wasn't actually curing sufficiently well. And that was leading to premature failures, of course. The thing I like about the SDR material is that because you have this little fine nozzle, you can actually get the nozzle right in there into your access cavity and inject and backfill with the SDR at 4 millimeters. So I've done my etch, I've done my dentine bonding, I've light cured my dentine bonding, and I then backfill with SDR 4 millimeters. And then I can have 4 millimeters, 4 millimeters, and then I can just cap with something like ceramics, is what I use in my practice. Something like just ceramics mono on top of the SDR. And that's what it looks like. This is on an extracted tooth, because I'll show you in a moment what it looks like sectioned. This is what I just did in my practice. So we have one layer of SDR up to 4 millimeters, another layer of SDR, and then the final 1.5 millimeters, 2 millimeters in ceramics mono. Now, one of the worries and one of the difficulties in root-filled teeth is we have an access cavity which is a class 1 cavity, and I'm sure we've all heard of the C factor or the configuration factor, which is the number of surfaces bonded divided by the number of surfaces unbonded in a cavity. And when we have a class 4 cavity, so we have like a large incisal edge here, we have a very low C factor. 2 bonded surfaces divided by 4 unbonded surfaces. And when we have a class 1 cavity, the C factor goes up by a factor of 10, because we have 5 bonded surfaces. So we have the 4 walls of the cavity and we have the base of the cavity, and we only have 1 unbonded surface, which is obviously the occlusal part of the cavity. So we have a 10-fold increase in C factor. And as the C factor increases, the polymerization stress and the strain do become a lot more significant in maintaining the bond and maintaining a marginal seal. So it's almost like the worst possible cavity to fill with composite would be a root filling access cavity. So Van End and Monk and Van Meerbrick and others looked at this particular problem, the bulk filling of high C factor posterior cavities and the effect on the adhesion to the cavity bottom dentine. And their conclusion, because they looked at SDR, was that the data is very favourable, and that it implies the bulk fill flowable based material SDR can be cured in bulk without harming the bond to the cavity bottom dentine. Okay, so this is a technique that I've been using now for about 1.5 years, and again, I mean, it's early days, but no issues, and the research that's come out about this would seem to be supporting this technique. So that would be my usual technique, which would be to place my root filling using gutter core and AH+, and then a dentine bonding agent, and then SDR, normally 2 layers, 4 millimeters or so each, and then capping with ceramics. And then also normally these teeth are going to require onlay restorations. So normally ceramic onlays or sometimes composite onlay restorations. And so my SDR or my ceramics is great also to bond to. And as I said earlier, it's a section tooth. So this is what it looks like sectioned. We have the gutter core and the AH+, and then this whole section here is my SDR, and then that's just capped with ceramics. And one thing you'll notice, no voids within the material. Okay, very, very quick, very, very efficient way to fill up an endodontic access cavity. So we'll look at another case just to sort of illustrate a few other points. So we go back. So this amalgam is failing. We have fracture lines here and caries, and we remove the amalgam and the fracture lines, creating this MO cavity. Now, a few basic principles. I nearly always just use round diamond burrs for my preparation, so we get nice rounded internal angles, so it's much easier for the composite material to adapt itself. I'll talk about in a moment. I quite like using air abrasion, particularly when I've removed old amalgams. And then comes the question of chamfers. Do the increased bond strength They certainly improve aesthetics when chamfers are placed on the occlusal surface. They certainly can help with adaptation. The Journal of American Dental Association in 1999 looked at this, Hilton and Farrakhan, and essentially what they said was that there's not really any difference, I think, in your sort of micro leakage and what have you on the occlusal surface, although there's better aesthetics. But beveling the vertical walls of your box, so beveling here, hopefully you can see that, and beveling here, you do get significantly less facial and lingual wall micro leakage. And you can do that. It's quite tricky to achieve. You certainly need really good magnification, so loupes or a microscope. You can use a fine burr, or the other option is to use something like a sonic scaler with little diamond tips that are designed for that. So if anybody's interested in wanting to create these beveled vertical walls, just drop me an email, which I gave out at the beginning of the webinar, so ianklein@mac.com, and I'll tell you where to get those tips from. So I personally do bevel here and here often, but I never really bevel the occlusal surface. I do like to use air abrasion. I use aluminium oxide powder, normally 50 micron or 27 micron particles in something like this, which is what I have. It's a Cavo Rondaflex. And what it's very good at is, if we look at this, the photograph on the left, where we used a split down technique, and I've removed two old amalgams, there's still a lot of bits of amalgam and debris in the 5 here, and just by air abrading, so I've not taken a burr to it, just by air abrading, it just cleans out all of this amalgam, and it helps sort of brighten up the tooth. So I think air abrasion is very useful, and I think also it can only help, I think, with bond strengths, particularly to enamel. There's the literature would say 2 different things about bonding to dentine, so we'll not get into that now. I'll place my Paladent Plus matrix band, and then we'll do in this case I'm going to use a 5th generation bonding agent, Prime and Bond NT. So I'll do a total etch technique, so no more than 15 seconds on onto the dentine with my phosphoric acid. And then I normally suction dry, leaving moist dentine, so we don't over dry the dentine, because that gives us collapsed collagen fibrils, which aren't so great to bond to. So we don't over dry the dentine, but try and dry the enamel. And as I say, I normally suction dry with the high volume suction. Apply my dentine bonding agent and light cure that. Then we can just apply the SDR up to 4 millimeters deep. So normally in a cavity like this, I'm only going to use 1 layer of SDR because I need to leave about 2 millimeters on the occlusal surface. When I'm applying the SDR, I keep the tip within the material. This just avoids any bubbles being incorporated into the material. And then I also just let the material just self-level and just relax by itself, normally about 5 seconds. And if you're wearing loupes or you have a microscope, you'll see this quite clearly as it settles. And then we hit that with the light cure for 20 seconds. And then we just apply the capping material, which in this case is ceramics mono. And then we, as you'll see here, we've got a nice tight contact area. And then I'll just adjust the occlusion and then polish that with an enhance finisher first of all. And then finally just an OptiShine polisher. This is a silicon carbide impregnated polisher. It's not just a bristle brush. Silicon carbide particles within the brush. It's autoclavable normally for about 50 cycles. And this just creates a nice high shine, literally in sort of 20 seconds or so. So very, very simple finishing and polishing. Now, a few words on light curing. I think the most important thing is to buy a good quality light cure unit that you're sure of the source that you know that it's got a decent power output of 1,000 milliwatts per centimetre squared or more. So something like the Smart Light from Dentsply. This study found in 2002 concluded that 37%, that's an awful lot of composite restorations, were insufficiently cured. And Dunn and Miller in the British Dental Journal back in 1996, they did a survey of light curing units, and they also found that dentists were under curing composites. And this was for a variety of reasons. There was perhaps bits of composites stuck on the end of the light cure unit, which were reducing the effectiveness, or perhaps there was the chips or marks on the end of the light cure unit, or just that the light power had reduced in effectiveness. So it is very important to test your light cure units. It's less of an issue with the LED lights than with the halogen, the old halogen lights. But you should be testing your unit, I think, at least once a month, just to make sure it's giving you the output that you want and that you think. The other thing is, where do you point the light? Certainly when I was at dental school, I was always taught to point the light source, say in an MOD cavity. I would point from the buccal surface first, and the idea being that the composite would shrink towards the light, and then I would then I would place another increment and then cure from the lingual, and I would be curing from the sides all the time, curing through the tooth, that this composite would shrink towards the light. And I've seen this in textbooks still, and I've also heard people still talk about this in lectures. Versluis, though, looked at this back in 1998, and he very much, I think, answered it. Do dental composites shrink towards the light? And the answer is no. All that happens is if you shine the light through the tooth, expecting the composite to move towards it, is that you reduce the power of the light source to the composite enormously. So all your curing should be done from the occlusal surface, and you should get the light source as close as you can to the material. And if your assistant is holding the light source for you, make sure that the assistant holds the light source still, not moving it around, not lifting it up, because if the light cure unit is even like a centimetre away from the composite, and then let's say it's in a root-filled tooth, which that composite is another centimetre away, the amount of power getting to the composite is really not enough to cure it. So the key thing is really have a really good light cure unit. Do test it. I would say once a month. You can buy these meters relatively inexpensively now, and always cure from the occlusal surface. Don't cure from one side or the other. Just another quick clinical case for you. This girl was actually a dentist. This lady's a dentist, and she had this temporary restoration in her upper sixth here. Now, I'm actually going to use SDR in this case, but one thing to note is when she smiles, you can see the temporary restoration. So this might be a little bit of a contraindication because SDR is a little bit translucent. But I'll show you how I tackled this. So this is the temporary restoration that's been in there for a few years. It's all worn down. We remove the temporary restoration. We've obviously placed rubber dam in this case, and then we have sectional matrix, and wedges, and then the clamps holding that all in position. And then because we can, when the patient smiles, we can see this area, what we'll do is actually build out this part of the tooth first in enamel shade, So this is something like an E1 or an E2 shade from ceramics, and then a dentine layer here, and then we can bulk fill the rest of it with SDR. So you'll see the differences in the translucency of the material. We've got an enamel shade here, we've got the dentine shade here. So when the patient smiles, it'll look like a tooth, and then we'll bulk fill. So it's very quick to fill the rest of it with SDR, and then we can then cap with either some dentine shade in this case, and then enamel shade on the top. And that's what we end up with as a restoration. So before and after. A few little sort of tips on creating anatomy. This is a case I did a couple of years ago where we have some failing ceramic, I think they were, inlays. These had been placed literally a couple of years previously, I think by a dentist in Italy. Well, certainly the patient was Italian. And these had failed. I don't think there was any reason to be using ceramic inlays in this kind of situation anyway. Direct composite, I think, is more appropriate. So remove the restorations, rubber dam as usual. And this case, and if people say to you, well, SDR is not aesthetic, this case is with SDR and with one shade of ceramics. And the way that I create my anatomy, very, very simple, micro brush and a probe. So not really any fancy instrumentation. Micro brush to adapt the layers. So I bulk fill with SDR. Micro brush just to adapt the ceramics. So we don't need to use the micro brush for the SDR. The SDR will just self-level like so. And then we'll use the micro brush for the ceramics mono layer on top. And then I'll create my anatomy just with a probe. And that's the result. No fancy staining or anything. The patient was delighted, I was delighted with photographs. And that's just using SDR and ceramics. And then the other quick technique, I think, for creating really nice anatomy is where you have good anatomy already, as in this case. So, and this is something called the Memesil index technique. And it's also, there's a variation which is sort of doing the rounds on Facebook at the moment called the stamp technique. So the Memesil index technique. So we use material called Memesil, which is this from Heraeus culture, Memesil 2, which is basically a clear silicone material. And what we can do is take an impression as the patient's going numb. We'll take an impression of the occlusal surface, and we end up with this template of the occlusal surface. We can then prep, do our preparation, and then once we've done our preparation like that, we'll etch dentine bonding agent, SDR, leave it shy for that 2 millimeters, light cure the SDR, and then we would put our layer of something like ceramics mono on top, and then we would press the Memesil silicone index back over the tooth, make sure it's firmly in place, and then actually light cure through the Memesil. This is why it needs to be a clear material like Memesil. So we light cure through the material. And then when we remove the Memesil, this is what we end up with. So we have our anatomy created for us already. And so that then requires very, very minimal finishing, like so, and polishing, enhance, OptiShine polisher. That's all we did. And that's the case in 2008 when I did that case originally. When I saw that I see the patient every 6 months, every year or so for his routine examination, and that's the case in 2015. Okay, so it's not had any detrimental effect, as I can see, on the composite, on the material itself. It's all functioning perfectly well. Now the stamp technique, which is a variation on this, what you would typically do is you would use something like a liquid dam material, like a liquid barrier material, and you would squirt that over the occlusal surface before you do any tooth preparation. Light cure it, and then light cure it with something like a microbrush stuck into the material, and then remove that. Again, as with the Memesil index technique, you would place your final layer of composite, not cure it, and then basically stamp an imprint back into the material. Some people use Teflon tape, PTFE tape, polytetrafluoroethylene tape as a separating medium. So they'll put the PTFE tape over the uncured composite and then stamp, and then either cure through the Teflon tape or peel off the Teflon tape and then light cure. So it's a stamp technique. And if anybody wants to see slides of that technique or interested in that technique, then again, drop me an email. So in summary, hopefully you've enjoyed the webinar. I think I have a few questions, so I'm going to go through those in the last 5 minutes. I did actually write a few years back a how-to guide posterior direct composite restorations, which is available as a PDF. So if you'd like a copy of that, again, drop me an email, or you can just Google my name and the how-to guide posterior direct composite restorations PDF. You'll come across it. I've also done several other webinars for the Dentsply Academy, including one on anterior composites, one on the dial concept for treatment of tooth wear, one on dental photography, and one on rubber dam technique. So if you like this webinar and you've not seen the others, then please take a look at Dentsply Academy.